We'll move on to our next session on screen, coming up real soon. Now, a lot of people have walked into the hall just for this session. So, the topic is erectile dysfunction, practical tips and emerging therapies. And we'd like to call up on stage Associate Professor Dr. Stanley Chan from University. Dr. Stanley, thank you.
Hi, good afternoon, guys.
Good afternoon.
This is second last, so usually the organizer will reserve the best to the last, second last not too bad. Okay, without further ado, I think we should start. So it's just here, I think Dr. Chua shared a lot of the stem cell, the high tech. So here, more of a primary care technique. So you see, primary care doctor, we see different patients. So patient come in for fever, come in for GI problem, whatever, and suddenly patient say, hey, doctor, I have erection problem. So as a primary physician, how do we do? Because we have a very busy day, what we want is straightforward. The thing is straightforward, so we know, yes, if patient comes with this condition, at least I can do something for the patient. Okay. Some introduction about myself. So I graduated from the University of Calgary, Canada. So after that, actually I went to the state, America, for both my residency and my fellowship. So my fellowship, my residency of course is family medicine, so I'm a consultant, so I'm a family physician. And my fellowship, actually I specialize in training specialists. So train all these American doctors to become specialists. Here in Malaysia also we train people to become FMS. So this is my expertise. Of course, so I came back from America and then I joined IMU. So until now. And at the same time, I also started a mental health practice. So maybe more than 10 years ago, you guys have heard about mental health practice. So I think I'm one of the few pioneers who started all these things. And I'm also the pioneer who first introduced the low-intensity shockwave therapy for treating erectile dysfunction. I think nowadays you guys also have heard a lot of clinics are actually doing that. Just to show that, I'm quite active in the international, also local men's health and sexual health association. So I'm an EXCO member for the Malaysian Society of Andrology and the Study of Aging. I can see that, and aging male. So I'm also the committee chairman for the International Society of Sexual Medicine. And last year I was invited to Spain, where the world expert will get together, and then we go over the literature and then come up with guidelines. Okay, so it's actually it's invited by the 5th International Consultation on Sexual Medicine. Okay, here are the main topics. So we're going to go over the differential diagnosis of ED. What are the tests that we can do? And also how do we manage as a GP or primary care physician? Okay, let's start with differential diagnosis. Causes of ED, there's a few causes, but actually big 3 categories. First category is failure to initiate. So the guys, in order to have an erection, there's a few things that has to be intact. First, mentally, so psychogenic, mentally, the guys cannot be too anxious, cannot be too depressed, they cannot have erection at all. That's why most patients actually are actually coming in with because psychogenic, is a main cause of ED. Of course, nervous system, so patient have a stroke, or have a brain cancer, or have a spinal cord injury, of course, cannot really have erection. Hormonal impairment, there's 2 hormones that commonly affect erection. One is the testosterone, the second one is thyroid. These are the 2. Of course, some medicine that we give can actually contribute to ED. Okay, next is a failure to feel. This one actually about atherosclerosis. In order for guys to have strong erection all the way, then the blood vessels must be healthy. Because if the atherosclerosis, then the blood flow will be interrupted. So the guys may not have good strong erection, or the erection cannot last. Okay, last one is a failure to stall. So as we know, once the blood goes in, it has to be there. If not, then erection cannot sustain, it has to sustain hardness. So this one, venous leakage or aging penile tissue will cause a problem. But these are not the common conditions that I see here. Maybe urologists will see more. Okay, so point. Where's the pointer? This way. I think it's pointer. Ah yes, pointer is it. Okay, doesn't matter. Okay, so you see, pick two categories. Patient with ED, first, whether it's psychogenic, second, whether it's organic. And then under organic, we subcategorize into three. One is something related to the vascular, so vasculogenic, or non-vasculogenic, or mixed. So is it pretty simple, straightforward, not too difficult. Okay, here are some features. So next time a patient comes in, you want to see whether the guy is more likely to be organic or something up here, whether it's psychogenic. So patients who have organic, usually they are older, so about 50s. ED came on gradually, so it's not just suddenly, it just came on gradually, getting worse slowly. And then these are the patients who have loss of nocturnal penile tumescence or early morning erection. So basically, these are the physiological erection. So the patient will lose it if these are organic. So ED in all situations, you cannot blame wife, you cannot blame other people, you just blame yourself. For psychogenic, yeah, this one is younger guys with sometimes called transient ED. So the ED came on suddenly, it can. Suddenly, a young guy wake up in how come that direction. And then the severity may vary. Some can suddenly become very severe, some very mild. Okay, you see, the physiological, the nocturnal penile tumescence or the early morning erection usually is intact. So that's why this is the thing we ask patients, how's your morning erection, whether you have erection in the morning, especially when you feeling there's an urgency, before you pee, to see whether you have the erection. So that is a common question I ask patients. Okay, this one, ED, yeah, in some situations. I do have patients come and say, doctor, I have a problem with my wife, but I don't have problem with other girls. So what's wrong with me? Then I think you guys have to talk to the marital counselor. I'm a physician, I'm not a psychologist or counselor, couldn't help them with that. Okay, as you can see again, so the etiology, the organic etiology, big chunk of it, diabetes, primary care physician, GP, we see a lot of diabetes patients. I think even now physician, a lot, hospital, a lot, you see. Diabetes, 40%, vascular disease, 30%. If these are organic causes of ED, most likely it's related to vascular or diabetes. Endocrine, 5%, spinal cord, not too many cases. This one is to show you how common ED in a specific group of patients. First one you can see there's coronary artery disease, 90%. Hypertension, 62%. Diabetes, 51%. Okay, the first one, the study was done in Malaysia. This one was done in UMMC. And then the last two, of course, by American. What you can see that ED, vasculogenic ED, is very common in patients who have hypertension, patients who have diabetes, especially patients who already have heart conditions. Therefore, there are strong links between the ED and the cardiovascular disease. ED can be a vital clinical clue signaling undiagnosed cardiovascular disease. So next time when we see patients say, doctor, I have ED, and then don't just look up here, heart, very important, cardiovascular disease. Okay, you see, these are features. That's why as doctor, we take a very good history. Short history can, this one. You see, ask patients may have hypertension, diabetes, dyslipidemia. These are the risk factors for atherosclerosis. Then it's similar for vascular ED. Okay, here there's a bunch of it, non-vasculogenic. So as a primary care doctor, as long as you know what's vasculogenic ED, then we can kind of give something to treat already. So we need to think about all these things. There's too many things. Endocrine, like I say, something related to cholesterol. Okay, proctoloma, a patient coming with proctoloma, hypothyroidism, locally, penile problem, or prostate problem, all these things. So many. But these are the things that can help you to make diagnosis in very short amount of time. First, we can use IIEF, fine. DAS21, this one is a good screening tool if you suspect a patient who could have depression, anxiety, or stress related. Okay, there's a medication list. You can go to the MedLife class with the government. This one has a lot of the good medication list to see what are medication that could cause ED. Okay, this one is just a questionnaire for IEF. This one you can get online easily. Basically, ask you 5 questions, and then over the past 6 months, how the performance has been. There's a very low. Basically, is to say the confidence of patient getting the erection or having a sexual intercourse is a confidence. So patient will rate that. Then after that, the total score, then we categorize either severe, moderate, mild, or normal. Okay, this is DAS 21. You can also download online. This one is a MedLife class. Okay, so these are drugs and cause erectile dysfunction. There's a lot of things. That's why we couldn't be memorizing everything. Okay, in terms of investigations, if you take good history, most of the time you don't have to do an investigation, but sometimes if you really want to do an investigation, these are the evidence-based ones. So these are, I think, fasting lipid, fasting glucose. These are two related to vasculogenic ED. So TSH, thyroid, we want to make sure that it's not a subclinical thyroid, things like that. Or hypogonadism. Hypogonadism is best to do the early morning serum cholesterol because our cholesterol peaks in the morning. So best to do it before 11 a.m. Best, of course, is fasting. So fasting, total cholesterol, serum cholesterol, at about 8 o'clock, 9 o'clock, I think is good enough to give us the picture. Okay. Of course, after we take a good history, we do the investigation, then how do we manage? Conventionally, first, if we can, we treat the underlying. So we treat the underlying. If medication, of course, normally I would switch medication. So of course, if the medication is very important, there isn't any alternative, then we reduce the dose. Of course, lifestyle, things like that, of course, we do have to ask some. If you don't have time to have ask also, no problem. Okay, treatment options. First line, lifestyle. Why do we emphasize on lifestyle? Because it's a good time to emphasize the patient that ED can be caused by blockages to the blood vessels. So therefore, exercise, quit smoking, adopt heavy diet, it's very important. Yeah, I re-emphasize to all my patients. Yeah. Okay, second line. Of course, you can do injection. So most of the GP, primary care doctor will do. So urologists, some they may do. So here they can get injection. They get injections of prostaglandin inside. They call it prostatil. So the brand in Malaysia is called Coverjet. Coverjet is actually not cheap. It can cost about maybe 150 to 200. And then most of patients, if you want to buy a good pharmacy, you need to order. So that's why it's not a good option that Malaysian patients want. Of course, they need to learn how to do injection also. Okay, third line, of course, you refer to your urologist colleagues. This one is you can do either implant or either do vascular surgery if this is like a venous leakage. Okay, next, it's more interesting. It's called new treatments, new modalities for vasculogenic ED. So I focus more on vasculogenic ED. Okay, so outside there, so you can see there's a one-man spec, another one is a piezo wave, things like that. So people claim that, low intensity extracorporeal shockwave therapy. Whether it really works. That's why first we want to see whether there's any evidence behind. So here I have a systematic review. Okay, later on I'll show you a systematic review. Here, just to show you what the basic science behind. Why does this therapy work in the first place? As you can see, it can promote the angiogenesis and improve its blood supply. So there's some basic science studies being done. And then it showed that it can stimulate the expression of the angiogenesis-related factors, such as vascular endothelial growth factors. So these are the things we will stimulate. So this is the basic science behind. Okay, as a doctor, basic science is fine, basic scientists have done the job, now it's our turn. Whether it works in a clinical setting. Okay, systematic review with meta-analysis. If according to the level of evidence, this is level 1 evidence, no doubt. If it's done well, of course, this one is done well because it's published in the American Journal of Mental Health. So this is like a tier 1, tier 2 journal. Okay, what is this study tell us about? Okay, first, it evaluates the efficacy of course, the low-intensity extracorporeal shock therapy in the treatment of ED. Okay, the authors systematically search for PubMed, EMBase, Cochrane database, things like that. So actually, they identified 16 RCTs. So including about 1,000 participants, I mean, quite a lot. Okay. From what we can see here, 12 articles provide IEF. So just I'll show you what's IEF. IEF is a scoring system. So actually here the outcome we use the IEF to see whether it changes to the IEF. So 12 articles provide IEF at 1 month follow-up. And then the 8 provided at the 3-month follow-up, and unfortunately only 4 provided for the 6-month follow-up. So it's like 1 month, yeah, a lot of studies show that. 3 months, yes, more, and then lesser and lesser. Okay, here the risk of bias basically to tell you that what is the, okay, we need to assess the quality of the RCT because we included 16 RCT. We want to see whether the RCT is good or not good. You know, here's very easy, so I'm not here to teach you about 16 like that. Very easy. Green is good one, low risk. Red is a high risk. You can see more green than red. So it means the quality they included is quite they were good quality. So that's why it's not so typical. It's quite simple one. Okay, here for the meta-analysis, so usually we will do a false pause. Okay, how to look at false pause, all those things. Okay, for the conclusion, it's very simple. What you guys can see, that's a diamond shape. The diamond shape. Okay, because meta-analysis, they pull all the data through the calculation, then we look at diamond shape. So the first one is 1 month follow-up, the B is a 3 months follow-up, and the C is a 6 month follow-up. So what we can see, also pretty easy. One is control, one side is experimental, so we treatment group. So if the diamond fall into the experimental group means the treatment group perform better than control or than the placebo. So it can show you at 1 month follow-up, 3 month follow-up, and 6 month follow-up, the low intensity shock wave therapy actually does better. Okay, another outcome those authors look at is called EHS, Erection Hardness Score. So the erection hardness score, 8 out of the 16 articles provided the data. So improvement, okay, what we want to improvement is we want to see at least from 2 to 3. Why 2? 2 patients cannot penetrate. That's why clinically useless, even though it's significant. But this one, 3 is 3. 3 is there is a banana with a skin, but it's still super hard, but still can penetrate. Okay, they look at these things, and then they want to see whether there's an improvement. You can see that the odd ratio 5 times. What does it mean? It means that the treatment groups actually there were 5 times more likely to get the EHS improvement as compared with the placebo. Okay, first of all, data is significant. Yes, P less than 0.05. That's why it's saying significant. Good. Then the next thing we're going to say, whether clinical significance. Is it effect size is 5 times more? No. 5 times more means significant, good. That's why good is exercise. So based on systematic review that they did, whether low intensity shock wave therapy really works. Yeah, the evidence shows us, yes, there's relevant evidence. It shows that it works. Okay, next, we'll cover a bit about PRP, P-shot. It's quite common because some patients come in and talk about P-shot. Okay, just roughly about P-shot. P-shot basically is to extract the platelet, spin, centrifuge, and after that, they extract the platelet-rich plasma. This is a platelet-rich plasma. Why? Why do we want to do that? You see, because it contains some growth factors, a lot of growth factors. These growth factors may stimulate angiogenesis, regulate our inflammation, and wound healing, things like that. Okay, here is a systematic review on a platelet-rich plasma. Why this one without meta-analysis? Let's show you why it doesn't have a meta-analysis. This one is systematic review. Okay, so they went through a lot of studies, but they identified 4, which consider a trial. But to me, the first one is not randomized, no placebo. So I don't think really is a good clinical trial. It's not really RCT. So I focus more on the last 3. So double blind, not bad, prospective, randomized, all these things. And so you can see, the number of treatment is different one. Some study did 2, some study did 4, not 4, I think 3. 3, 2, and then the interval of the intervention is a bit different. Some is 14 days, some is a month, In the sense that all the study designs are different. Therefore, we cannot pull the information together to do a pause, no way. Because each of them is an individual study. But what we can see, the last one, go for last one first, because there's no difference. So it means both the P-shot group or the PRP group and the placebo group also improve. The performance improve. And the middle two, you can see that there's significant improvement in the intervention group as compared to. So that's why the study information, what we find so far, yes, somewhat study, somewhat evidence, but not strong. Not as like the low intensity shock wave therapy. Okay, this one is what about guidelines say? So my urologist colleagues usually tell me that, yes, Malaysian urologists, they prefer to look at the European guidelines instead of nice guidelines or even American guidelines. So they say European, so they follow European more. So this one is the European guidelines. What does the European guidelines say about the new mortality? Okay, you can see that here. The use of low intensity shock wave therapy in patients with, they recommend with mild or to moderate vasculogenic ED, or if the patient want to cure, so patient say, I don't want to take medicine, I don't want to take any PDE5 inhibitor, then yes, patient can choose to do that. This one, the guidelines they follow, this one will be, so this is the guidelines they follow in the European countries. So actually they can ask doctor, I don't want to take PDE5, I take all this Viagra, whatever, I will have headache, things like that. Then yeah, the insurance will cover that, pretty much. Okay, or patients who are non-responsive to the PDE5 like tazolafil, lacetilizumab, then if they don't want to go for surgery, if a patient don't want to go for any injection or Carbojet, then that is another option that patient can go for. Okay, fine. Now follow up. So of course, after you treat the patient, then come to a follow up. Of course, as a good family doctor, you need to do all these things. Okay. Last, take 4 points. First, rule out psychogenic cause. Because psychogenic, we don't know how to deal with it. It's very troublesome. We only have 5 minutes to see one patient. Therefore, we refer out. Second, rule out non-vasculogenic. Non-vasculogenic also quite difficult for we need experts to help, especially if a hypogonadism or if a patient has a prostate problem, then better refer to your urologist colleague to do that. And then for vasculogenic also it's easy. First, it's vasculogenic ED, first line, ask the patient to exercise, quit smoking, things like that, and then give them some medicine. You can either do the sildenafil or tazolafil or ventilafil. So manage the underlying. Oh yes. Okay, any questions?
Do we have any questions from the floor?
Straightforward. Good. Okay. So this is my contact. So if you want to contact me, ask me any questions, so you can.
We do have one question here.
I want to ask, if my patient is 80 years old man with NCD cases, and what treatment that I should offer him? To see you?
Okay. Okay. Actually, I have successfully treated patients who have. My oldest patient are 85 years old. So 80 years old, consider relatively young. With Dr. Chua, exosome stem cell, then of course it's very young. Because we anticipate to live until 150, you know. Wow. So 80-year-old, yeah, maybe tomorrow longevity, and then we'll talk about more. We are looking forward.
All right, ladies and gentlemen, please give a big round of applause to Dr. Stanley Chan. Thank you so much. If you have any other questions and so on, Dr. Stanley will be right around here. You can finalize your last minute questions.